Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. It's my pleasure to welcome you to the third of our three-part series of webinars looking at hepatitis C in pregnancy. Today, we'll be looking at strategies to improve linkages to care and treatment. We have as you'll see in a moment, we have a very excellent set of speakers to share their experiences and data from their studies, followed by a panel discussion again of experts in this field. For those that are coming to the Coalition for the first time, the Coalition is a part of the Task Force for Global Health. We started about 3 years ago to help bring people, programs together to share lessons learned and experiences as we're doing today regarding the ways to implement the prevention, care, and treatment services needed to achieve goals for hepatitis elimination. We also conduct a number of operational research studies and provide technical assistance to programs around the world. And we seek to conduct advocacy to bring more partners to the table to build capacity for hepatitis elimination, most recently helping to develop the first United Nations group of friends to eliminate hepatitis, which was launched by the embassy at the United Nations for Egypt last month. All of our work is available out on our website at globalhep.org, and I encourage you to sign up for our newsletter and follow us on Twitter so you can stay abreast of what or the latest developments in our mutual efforts to achieve goals for hepatitis elimination. Next slide, please. Here's the agenda. I'm going to be turning it over to my colleague, Dr. Neil Gupta, who has been, as you'll see in a moment, managing a registry of women who are pregnant who are receiving HCV medication, so we get more information about the safety of the and clinical outcomes of those women and their infants. I'll turn it over to Neil at this point, just to want to remark that all of the webinars are available up on the website of globalhep.org. And secondly, I really strongly encourage everyone to be an active participant in this webinar and share your questions and comments in the chat and in the Q&A functions that you see at the bottom of the screen. And at this point, I'll turn it over to Neil. Neil?
Wonderful. Thank you so much, John, and great to see everybody on the line today. Again, a big group, as we have had previously, well over 200 participants in each of our first two sessions, and we're grateful for your time and hope to provide you with real-time information that can really improve linkage and treatment for pregnant persons and those diagnosed during pregnancy with hepatitis C infection. Next slide, please. And next slide. So given the 3 sessions that we've had in this Community of Practice series, beginning in November with challenges to hepatitis C, linkage and treatment in pregnancy, and then in January, in our second session, really focused in on strategies to improve hepatitis C linkage and treatment in pregnancy. I wanted to show you some results that we had from the polling that we conducted amongst all of the participants in the first session. Apologies, this looks a little bit blurry, but we'll make sure to post this online in its clear format so you can have a better look. We asked 2 questions of participants in the second webinar of the Community of Practice. The first question was, which programmatic activities would you recommend to improve linkage to care for patients with hepatitis C in pregnancy? And this was, again, following several presentations that were describing models of care that different groups have taken and attempts that different groups have made to improve the care cascade for pregnant and peripartum individuals. And you see that participants really advocated and supported certain interventions such as co-location of antenatal and hepatitis C treatment services, training for antenatal care providers, integration of harm reduction or opioid use disorder services, outreach and follow-up from programs directly to individuals or clients, assigning patient navigators and patient communication materials. You can see more here to the right side, but a diverse set of interventions that could be employed to improve the care cascade for pregnant and peripartum individuals. Next slide. On question 2, we tried to dig a little deeper and say, given current available information and that which was presented in the first 2 webinars, which of the following do you believe are optimal strategies for the management of hepatitis C? And this in pregnancy and peripartum individuals. And we did say that you could check all that apply. So this wasn't exclusive categories. But majority of participants really felt that referral during the pregnancy period, as well as initiation of treatment during the pregnancy period, would be optimal strategies to improve the care cascade. And initiation postpartum, which we'll hear more about actually in our first presentation, or initiation after delivery in the breastfeeding period, were somewhat hampered by attrition or loss to care. So keep that in mind as we go through the presentations today. And I think it would be interesting to come back to a similar question later in the community of practice. Next slide, please. So I want to start today by just presenting our initial findings from the registry itself. And as a reminder, next slide, please. The TiP-HepC registry is a retrospective observational registry using routinely collected data from voluntary contributing centers or providers. Inclusion criteria for the registry are cases of individuals who are not only hepatitis C infected, but also with treatment exposure that's documented during pregnancy dates. So we collect information on maternal characteristics, as well as timing and duration, as well as specific regimen of the HCV treatment exposure. And the primary outcomes are pregnancy and birth outcomes for both mother and infant. And secondary outcomes are really around hepatitis C treatment outcome and infant hepatitis C status. Next slide, please. So just to give you a sense of the registry itself, and the registry is linked here, and we'll provide you with a QR code in just a few slides. We'll also drop the link in the chat here. For those of whom have not visited the platform, there's an easy question and answer type format there, and really some background information on what the registry is and what it's trying to accomplish. But as a quick recap, data contributors can access this portal directly. They can submit information for individual cases through a survey format or by uploading data in a data template. Data contributors can select if they want to submit data only for the maternal exposure and outcomes, or for both maternal and infants. And then following the submission, they'll receive an automated email with an identification number for each case. And the REDCap platform in which this is submitted will also reach out with targeted requests for necessary information that might be missing in the first round of submission. Next slide, please. So we launched this registry in July of 2022, last year. We did an open call for submissions. We partnered with the FDA to have this listed on the list of pregnancy exposure registries. We reached out to professional societies. We spoke to people at conferences and through peer-reviewed literature, and also connected with our industry partners to have this included in their information as well. We also reached out directly to centers and investigators, many of whom you'll see on the presenting list today, who submitted data from clinician-initiated case series or cohorts, as well as provider networks and other registries. So really a very inclusive group here that was submitting data for the registry. And next slide, please. And we recently posted the first 3 months of experience from July to October 2022, data that was reviewed by our scientific advisory committee. And for these next 2 slides, I'd really like to just point you to the policy document that we've posted online. The link is here on the slide, and we'll post it in the chat as well. You can go and download this initial policy brief that we have on our website. And we've broken down the data that we've collected so far to be, fully transparent with the submissions that we've received in this early experience. Registries, as we've discovered, are really a labor of love and a long-term experience. So the first 3 months, we don't expect, to answer the questions that we've set out for, but really wanted to share the proof of concept here. For submissions regarding cases of exposure in the first trimester, we received 3 submissions to date, and we have listed some of the outcomes here. This is fairly incomplete to date, but we hope to accrue more cases as we go along. Next slide, please. In terms of submissions for individuals exposed or treated within the second or third trimester, we received 20 submissions to date. And those outcomes and safety data are listed here and are published within the policy brief. Those cases were all previously published in the literature as well. So this is a nice way to bring those together into a more aggregated format and could be used by providers when considering prior authorization for treatment during pregnancy, or even in communication with patients themselves regarding decision-making for treatment decisions during pregnancy or in the early postpartum or later postpartum periods. Next slide, please. Some early challenges that we faced. One is primarily first trimester cases really waiting for the outcomes to accrue. And that will happen over time. And we're looking forward to reaching back out to cases that are submitted to really follow up with outcomes. Third trimester treatment was all from published cases at this point, but we have had cases since this interim analysis was conducted of cases treated in the third trimester that are not actually published in the peer review literature. So we're optimistic that that will continue to accrue. We know that cases were difficult to recall for individuals, but are on the lookout now, providers that are on the lookout for future cases of treatment exposures. And we've been in contact with other registries and in other countries to overcome regulatory or information sharing barriers and hope to include that in future iterations of the registry analyses. Next slide, please. We were very pleased that the platform is now up and running and that there's high general awareness and distribution of the registry, not only with professional societies, but also with our industry partners. And we look forward to using the registry to have to be a broad base for this community of practice that's come together today. Next slide, please. So just a QR code here, feel free to snapshot it. And we look forward to your case contributions in the future. Please do reach out if you have any questions regarding eligibility or any other questions regarding the registry. So thank you so much. And with that, I'm going to go ahead and go back to our agenda for today. And I will gladly pass it over to our first speaker, invite Dr. John Cafardi. John is an assistant professor of medicine at the University of Cincinnati and is at the Christ Hospital. We welcome John, and John, I'll pass it over to you. Thanks so much.
Oh, good afternoon, all. And thank you so much for allowing me to participate in this today. Excuse me, while I pull up my slides here today. I assume these are correctly shared.
Looks great. Thanks, John.
Looks great. Thank you so much. So today I wanted to speak on a study that we have done in our linkage to care and postpartum treatment. These are my financial disclosures. I've served on advisory board for Gilead Sciences and received grant support from Gilead, Merck, AbbVie, and CTI Biopharma. Some background here. As we are all aware, unfortunately, postpartum linkage to care of both HCV infected mothers and testing of infants at risk has historically been quite poor. One of the seminal studies on this was done from Philadelphia, and they looked at the population from January of 2011 to February of 2015. There were 537 children born to 500 HCV positive women. Of these, 84 had HCV testing performed, with 4 HCV infected children identified. That comes out to 16% of the children were tested and 1% of them were identified. Based on estimated vertical transmission rate from the literature, an additional 23 infected children were present but not identified. In Boston, from January 2014 to March 2018, the baseline linkage to care was roughly 17%. This is with linkage intervention. With linkage intervention, this increased to roughly 24%, while linkage intervention plus co-localization of care increased this to 52%. Integration of prenatal and HCV care is reported to increase linkage, identified in 1 academic centers. However, only 12% were treated, 2 through a clinical trial and 1 via postpartum treatment. Now, why would I? So as I include all this, we are seeing that linkage to care, treatment, and testing are 3 very significant obstacles. And though we have these wonderful therapeutic agents, they are not getting to the people who need them. So what we developed, what we proposed was this study. We did actually work on trying to come up with a good acronym, but that was abandoned. So I applaud Catherine for STORK. I think that was pretty clever. I wish I'd come up with something like this. This is an investigator-initiated study. It was funded by Gilead Sciences and sponsored here by the Christ Hospital. It was run from June 2018 through June 2022. And pregnant women who were identified at or before 36 weeks gestation and were followed 12 months postpartum. Maternal treatment with sofosbuvir velpatasvir, Epclusa, was initiated 6 months postpartum, and assessment of SVR12 was performed 12 months post-delivery. Importantly, subjects were required to cease breastfeeding before initiation of treatment, so they could breastfeed for 6 months afterwards, after pregnancy, but had to stop at that point because the FDA, because we did not have clearance for the drug to be used in breastfeeding. This was included in our informed consent and discussion with women prior to study enrollment. Maternal viral samples were obtained for archive at 36 weeks and infant samples at 12, 24, and 48 weeks post-delivery. And vertical transmission pairs, the purpose of this was to have any vertically transmitted pairs to undergo phylogenetic analysis. So results, we had planned an enrollment of 150 subjects, but this was cut back due to the COVID-19 pandemic. We wound up enrolling 54 subjects. Evaluable data was obtained on 49 mothers and 27 infants, and there was 1 confirmed vertical transmission. Of these evaluable individuals, 19 achieved a documented SVR12, and an additional 7 reported completing DAA therapy. By this, we mean they returned to clinic for new medications, they returned used bottles, pill counts were conducted and found that they were accurate. However, they did not return for an SVR12 visit. 1 withdrew after study enrollment, stating she did not want to stop breastfeeding and begin DAA therapy, which, as mentioned, was a condition of study participation. 26 were lost to follow-up and did not complete therapy throughout the study. Of these 26, 2 reintegrated to care at our institution following the closure of the study and are in the process of receiving DAA therapy. There was 1 additional patient documented who completed treatment at another institution. All of these individuals that we were able to follow up with reported difficulties with care coordination that they attributed to COVID-19 associated social challenges. So in summary, 35% were linked to care and achieved an SVR. 48% were successfully linked to care and completed treatment. 55% of the infants were tested with a 4% vertical transmission rate. The maternal viral load, in this case, the maternal viral load prior to delivery was 2.1 million with a genotype 3, and phylogenetic analysis of this transmitted virus sample is ongoing. And determination of remaining subject outcomes is in process. I guess we should say attempted determination, because a lot of these were very rural and we've been trying to follow up with them for years, but at this point, we're still continuing to attempt to reach out. So our linkage with care was consistent with observed historical trends involving linkage interventions and co-localization initiatives, 50 to 60%. Our rates of successful treatment were markedly higher than in prior reports, although the provision of medication as part of the study makes extrapolation of this finding difficult given third-party trends with given current trends with third-party payers. And I also will add to this that our test rates for infants were significantly higher than has been reported in the past. We believe that this is a result of both co-localization and making this co-localization of care and making it part of maternal treatment, that we don't separate out mother and infant, that these, as they came in for their study visits and their follow-up testing, mom was also getting treatment. We believe that was a key point to take away from this. That is all I have on these, and I look forward to presenting more on this as we have our phylogenetic analysis completed and hopefully some more data that is provided. Thank you.
Thank you so much, Dr. Caffardi. That was really I think, thought-provoking in many ways. I think many people will have questions being posed in the question and answer, and really regarding not only who is linked to care and completes the care cascade, but those who aren't, and some of the challenges that they're facing, and what type of interventions are required for them over time. But I think we'll hear more about that as the presentations go on. Thank you again, Dr. Caffardi, for your presentation. I'm going to pass over to Dr. Catherine Chappell. Dr. Chappell is an assistant professor at University of Pittsburgh Medical Center, McGee Women's Hospital, a great support for the community of practice over the past several years. And we're very much looking forward to her presentation today. Thanks, Catherine. I'm going to pass over to you if you want to share your slides, and we'll listen to your presentation. Thank you.
All right. Thanks so much, Neil. Does this look okay to everybody? All right. So I want to thank you guys for the opportunity to talk about our very recent presentation of the HIP-2 study, and then also what's been going on with the STORK study. As John mentioned, I cannot take credit for that acronym, though. I want to start where we left off. We presented HIP-1 for the first time at CROI in 2019, which seems like 1,000 years ago. And in this first study, we showed that there were no clinically significant changes in sophosphere liposphere that were attributable to pregnancy. In this study of 9 participants, it seemed to be safe, resulting in a 100% cure rate without any significant safety outcomes. We also did not have any perinatal transmissions. But half of our participants screen failed because they had genotype 2 or 3. So we really needed a pan-genotypic regimen really to move forward. And sophosphere valpatisvir was an ideal candidate because we already had a little bit of data on sophosphere, and valpatisvir is very similar to lidipasvir. However, before you do any larger study of a medication in pregnancy, you really have to take consideration to the significant physiologic changes that occur in pregnancy that can impact the drug exposures. And I won't belabor this slide, but I do want to mention that valpatisvir is quite different from lidipasvir in that it is metabolized by CYP3A4, and that enzyme is upregulated in pregnancy, and therefore it was critically important that we did this PK study prior to moving to a larger trial. So, so the HIP-2 study, our primary objective was to define the pharmacokinetics, safety, and virologic response to sofosbuvir/valpadosvir in pregnancy, and we hypothesized that similar to the ledipasvir/sofosbuvir study, that sofosbuvir/valpadosvir would be safe and effective in pregnant women without any significant PK changes. So these are the inclusion/exclusion criteria for the HIP-2 study. They were very similar to the HIP-1 study. We really wanted to have a pretty homogeneous population as much as possible, given this the significant complexity of the study population or the potential participant population. So we did exclude those that had hepatitis B or HIV. We also excluded those that had a history of cirrhosis and that had clinically significant drug use, as we didn't want in this first study to have any outside confounders to our findings. So this was our study design. It was very similar to the HIP-1 study. We started enrollment between 23 and 25 weeks gestation. This is after the majority of organogenesis, and actually probably most organogenesis, is completed. And really, so the risk of congenital anomalies is really not a risk. After enrollment and over the 12-week course, they completed 3 PK studies. 2 were intensive and 1 was sparse. And we pared down some of the PK because in our previous study, the HIP-1 study, we really didn't see that much difference over the course of gestational age. And we wanted to make this study as feasible as possible, especially considering we were enrolling during the COVID-19 pandemic. After delivery, all participants 12 weeks after completed treatment came back for the one final maternal visit, the SVR12 visit. And then we also followed the infant for an entire year, and that follow-up is still ongoing. This is our study flow. We screened 14 participants. We had significantly less screen fails in this study. We only had 3. Well, 1 declined to participate because of concerns about an investigational drug in pregnancy. 1 had a fetal anomaly that was identified prior, at her anatomy ultrasound done at 20 weeks. 1 had spontaneous hepatitis C clearance, although based on her report, that she would have had chronic hepatitis C, but she had clearance of her hepatitis C between screening and enrollment. 11 were enrolled. 1 participant had ongoing nausea and vomiting during pregnancy that worsened when she started sofosbuvir/valpadosvir, and she ended up discontinuing her treatment course because of this of her significant nausea vomiting. That was a lesson learned certainly for our study team. So after that, 10 completed the study medication and delivered. Even between delivery and the SVR assessment, we lost 2 to follow-up. 1 had a return to use, and the other moved out of state. And then we had 8 participants complete the SVR assessment. These are our demographics, and these are very similar to our HIP-1 study, majority white, majority with public insurance. We had a majority using tobacco. 4 of 11 were on medications for opioid use disorder, 2 on methadone, 2 on buprenorphine. Most had acquired hepatitis C through injection drug use. 1 reported a razor injury. Most participants had genotype 1 infection and 3 had genotype 3 infection, including the 1 who discontinued. So this is our PK results. And some of these are very similar to what we saw in HIP-1, and some are different. So for sofosbuvir, I really just want to focus your attention to this last, the geometric mean ratio. For those non-pharmacologists in the room, if it crosses 1, then it is similar. If it does not, then it is different. So the AUC for area under the curve for sofosbuvir was 38% increased during pregnancy compared to non-pregnant women. That Cmax was similar. What I will call, this is the inactive renally excreted metabolite of sofosbuvir. I'll call it 007. It was reduced, and that's similar to what we saw with the HIP-1 study. For valpatisvir, there was no change in the AUC, Cmax, or C-tau. This is our response data. As you recall, at enrollment, participants started sofosbuvir valpatisvir, and then completed a 12-week course. And as expected, we see a very rapid decline in viremia after initiation of treatment. All participants were undetectable at the time of delivery. And those 8 participants who came back for their SVR visit had undetectable viral load. So we had 100% cure rate among those who came back for the SVR visit. And I do want to mention that those 2 didn't come back, had an excellent treatment response, and were undetectable by the PK1 visit, which was 3 weeks after treatment initiation. And also we have not had any perinatal transmissions thus far as well. These are our obstetric outcomes. We had 7 that had vaginal deliveries, 3 that had scheduled C-sections, 1 that had an unscheduled C-section due to bleeding in the setting of placenta previa. We had 2 participants that delivered preterm. One was that participant that had bleeding placenta previa, and the other had acute cholelithiasis actually cholecystitis at the time of delivery, and they needed to operate and remove her gallbladder. So she was induced a little bit early and delivered at 36 weeks. So all the infants had normal birth weights. There was a varied length of hospitalization, some of it due to observation for neonatal opioid withdrawal syndrome. There were 2 or 3 infants that were admitted to the neonatal ICU, 2 for respiratory distress that responded rapidly to treatment and didn't have to stay very long, and 1 for treatment of neonatal opioid withdrawal syndrome. None of the adverse events that have been reported in the infants were deemed related to sofosbuvir valpatisvir. So in conclusion, from this study, valpatisvir exposures and sofosbuvir maximum concentrations were similar to historic data, but sofosbuvir area under the curve was 38% higher, and 007, both AUC and Cmax were lower, which is similar to HIP-1. Now, the elevated sofosbuvir concentrations could have been because of slow GI motility in pregnancy or to dietary variation in the current study compared to the historical control. There is some ongoing analysis to determine which of those it might be. 007 was reduced, likely due to increased renal clearance in pregnancy, and this is unlikely to be clinically significant because this is an inactive metabolite. However, we are currently measuring intracellular sofosbuvir concentrations, and so that should shed some light on whether or not this reduction in 007 is clinically significant. And based on both the HIP-1 and HIP-2 studies, that we really have some reassuring preliminary safety and efficacy data for both ledipasvir sofosbuvir and sofosbuvir valpatisvir. And this PK study is really supportive of a larger study to evaluate the safety and efficacy of antenatal hepatitis C treatment with sofosbuvir valpatisvir. And so that's what we're doing. We are doing a study called Safety and Tolerability of Outcomes of valpatisvir sofosbuvir for treatment of chronic hepatitis C during pregnancy, also known as STORC. This is a prospective, multi-center, single-arm study of sofosbuvir valproatovir in pregnancy in the US and Canada. The primary objectives are, one, to evaluate the sustained virologic response, and two, to evaluate the impact of antenatal treatment on gestational age of delivery. Our secondary outcomes will be maternal and neonatal safety, as well as we will determine the rate of perinatal transmission among this cohort. This is our study design. It's similar to our HIP-1 and 2 studies, except for we reduce the number of visits for ease. And these visits will align very well with prenatal care. So we will enroll participants between 20 and 30 weeks. They must have an anatomy ultrasound prior to enrollment. So we can know if there's any congenital anomalies present before we start treatment. There will be visits occurring every 4 weeks on treatment, and then a delivery visit, and then, of course, the SVR visit. And then similarly, we'll follow the infants for an entire year. Our study, we chose a multi-center single-arm design because what we have found in the HIP-1 and 2 studies is that doing studies of investigational drugs in pregnancy is really kind of a splitting topic, okay? So what I mean by that is that some participants are like, yes, I would love to participate in this study. And some participants look at me, potential participants look at me like I am absolutely crazy for even bringing up this topic with them, and some pregnant women really don't want to take any medication in pregnancy. And so we didn't feel like it would be feasible to have a randomized design. In addition, the sample size was also driven by feasibility. We hope to get 100 evaluable participants, and what I mean by valuable is that the maternal, we get the SVR for the maternal visit, or meaning the two primary outcomes, the SVR as well as the gestational age of delivery. This sample size will allow us to detect if there's a reduction in efficacy by less than 92%, or if the preterm birth rate is greater than 13% difference, and we will compare all of our safety outcomes to historical control. Recruitment for the STORC study began in July of 2022 in Pittsburgh, and then later the other sites were all activated by the end of 2022, and thus far we have 15% accrued. So I just want to take a brief moment to just talk about where we are and just a few thoughts about the importance of getting prospective data on DAs in pregnancy, because really, if our goal is hepatitis C elimination, we must include pregnant women into that. And I realize I'm preaching to the choir, but that also means include them in studies. And so we started planning the HIP-1 study back in 2015. That was months after ledipasvir sofosbuvir was approved, okay? And so we felt like we were really ahead of the curve, but even then we have this kind of strange time of purgatory right now, where we have a tiny amount of data about the safety of hepatitis C treatment in pregnancy, but not really enough to really say for certain if it's safe. So it really puts pregnant patients and their provider in a tough spot, because we know there are theoretical benefits, but the risks are unknown. So it's hard to really have an informed discussion. So we really have to have a more efficient pathway for data acquisition for drugs that would be beneficial in pregnancy. And this is going to take a collaboration with investigators like me, with the pharmaceutical companies like Gilead, and with the FDA to really figure out what is the safest mechanism and what is the timing of the data acquisition. Because without these data, there's really without these data, we really cannot achieve the dream of hepatitis C testing and treatment during pregnancy. So thanks very much for listening. And I just want to take a brief moment to thank my research team, my mentor, Sharon Hillier, our funders in ICHD and Gilead scientists, and of course, our brave participants without whom this work would not be possible. Thank you so much.
Thank you, Dr. Chappell. That was really data-packed, a lot to think about, and really our, I think, richest experience in how these medications really play out both physiologically and socially, biosocially with the patients that you're seeing. So thank you so much for going into detail there. And I think a perfect segue into our next speaker, who will now look forward a little bit and see what other data we wanted to present for this community of practice and the world in the years to come. So our next two speakers will actually look a little bit more futuristically on planned studies. Welcome here, Dr. HCV, who's an associate professor, Division of Maternal Fetal Medicine at Johns Hopkins University School of Medicine. Dr. Eke, thank you so much for joining us today, and looking forward to your presentation here. So let me pass over to you. Thank you.
Thank you, Neil. Thanks for the invite to speak. And like you said, this is a very good segue to speaking about glecaprevir pibrentasvir in pregnancy for people with hepatitis C. And just like Dr. Chappell said, I totally agree with all you said with respect to drug studies in pregnancy, which I have been doing. And I know most of the people here, both at the FDA level and the NIH, and we've all been working together to try to get a solution to how to move things forward. Next slide, please. So based on a couple of studies, some of them which you presented earlier on, and so many others that have been presented earlier, we in ACOG, the American College of OBGYN, decided to move ahead with universal screening for persons with Hep C. And we thought so because even though we don't have an approved medication right now to treat them in pregnancy, we felt that there are multiple reasons to proceed with screening of pregnant persons with Hep C. Next slide, please. And the reasons mainly which the speakers previously has talked about, if we identify them during pregnancy, while we don't have any approved therapy at the moment, we can actually identify them, connect them with the GI docs who would commence treatment immediately postpartum. And we've seen that more and more patients are being identified during pregnancy, even though we know that there are a lot of advantages to treat them during pregnancy. But for now, screening during pregnancy and then treating them postpartum is where we are. We're very hopeful that in the next couple of years, things are going to move forward with respect to treating during pregnancy. Next slide, please. So this is just a review that we did a couple of months ago, which was published, just kind of the landscape of where we are with things, and current ongoing studies, which some of them have been discussed here as well, and then how to move forward with them. Next slide, please. And so in the next few minutes, I will just discuss what we are doing with this study. So the IMPACT is the International Maternal Pediatric Adolescent AIDS Clinical Trials Network, which I know some of you know. A couple of months ago, we decided to proceed with the PK and safety of glecaprevir pibrentasvir in pregnant people with Hep C. Just like Dr. Chappell said earlier, this medication is one of the first-line medications used to treat patients who are treatment naive for Hep C during pregnancy. It's very effective and has been shown to be safe based on data from several randomized trials, which includes the Endurance, Expedition, and the Surveyor trials. And more so, this drug is also very effective for the genotypes types 1 through 6. So it's pan-genotypic in terms of its efficacy. And so we felt that we could look into this to proceed with how to study this drug in pregnancy. We also looked at the DART studies, which are the earlier studies in non-pregnant persons in animals, to see what the data was. And part of the things I do is I'm also board certified in pharmacology, so I also do those early PK work. And we realized that even with increasing the NOEL, which is you increase the doses of these drugs 5 to 10 times the dose, we did not see any signal, even in non-pregnant persons. And so we felt that it was safe to proceed, and we got approval a few months ago to proceed with this study. Next slide. And so this is just where we are. We are in the very early stages of this study. It's currently funded by the NIH. We are currently meeting every week to finish the writing phase of the protocol, which we hope to finish in the next couple of weeks. I'm hopeful that by April or latest by May, we will complete the protocol writing phase. Our aim is to recruit 30 patients who are evaluable. So we'll probably go higher to get patients who are PK evaluable, which is our main primary outcome. Then we're also looking at efficacy as well as safety. A couple of differences between this PK study and the previous PK studies of these DAAs in pregnancy. We are going to look at both HIV infected, co-infection, as well as HCV as well, because we know that a good percentage of patients who are HCV infected are also HIV infected. We are aware of the drug-drug interactions, and we're going to exclude any patient who has any drug that is an antiretroviral that might co-interact with a direct agent. And so our goal is to recruit 2/3 of them being HCV positive, and then 1/3 of them having a co-infection. The beauty of this therapy as well is that rather than 12 weeks, it will be for 8 weeks as treatment similar to the treatment in non-pregnant persons. And then we will be able to look at both the PK and safety. The other difference as well is we are going to start at an earlier gestational age. I have experience with doing these earlier drug trials. We would not wait for, we are going to likely recruit from 14 weeks upwards for a number of reasons. We felt it was safe, and having done that in a couple of HIV studies, we also felt we could proceed with it in this study. Hopefully, we're going to start recruitment by the early fall, which is towards September, October this year. I don't have much to say now in terms of inclusion, exclusion. We're still working all those details out. But hopefully at some other time when I have more, I would be happy to present that. And I'm happy to answer any questions later on. Thank you. And
thank you so much, Dr. Eke. That was, I really appreciate, and I think we as a community of practice really appreciate your openness to sharing, that early ideas and design around this, as it's important to us, for us to know what's coming down the pipeline and what we can expect, in the next year or two, in terms of data to guide practice. So thank you so much for that. Also, I'm going to call our next speaker, Dr. Lizzie Chappell, to the podium here. And Lizzie is a senior research fellow at the MRC Clinical Trials Unit at University College London. And similarly, sharing with us early thoughts on a proposed study and taking a bit more global, international look at the feasibility, potential safety, and efficacy of TAAs during pregnancy. So thanks, Lizzie, for joining us today, and to your entire group for participating in the community of practice over the past few sessions. Over to you. Thank you.
Absolutely. Thank you, Neil. And hi, everyone. Good morning. Good afternoon. I hope everyone can see my slides. I'll carry on assuming so. So I'm really pleased to be here presenting our study on behalf of the whole trial team. So this is a project that's being co-led by the MRC Clinical Trials Unit at UCL in London, and also the Aga Khan University in Pakistan. And as Neil said, this is a proposal which is currently under review for funding by the UKRI Applied Global Health Research Board. So as we've discussed today, the core question here is really about the risks and the benefits of DAA treatment in pregnancy. So the potential benefits on the right-hand side of the slide are that we cure the mother and we prevent vertical transmission of hepatitis C to the infant. And of course, if the mother is cured, that prevents vertical transmission in future pregnancies as well. And it may be that treating a pregnancy reduces the risks of complications resulting from hepatitis C itself in pregnancy, so preterm delivery, for example, but maybe not, especially if treatment is started later in pregnancy. So that's why this one's in grey. And then the potential risks on the left-hand side, that there may be adverse outcomes, so mainly risks to the infant, for example, birth defects. And some of these potential risks from DAAs overlap with complications from hepatitis C in pregnancy. So we want to make sure that by treating women in pregnancy, we're not leading to poorer outcomes in these respects. So with this in mind, what we want to show in our trial, our hypothesis, is that safety outcomes of DAA treatment of pregnant women during late second and third trimester are non-inferior to current standard of care of no treatment of hepatitis C during pregnancy. And then also that DAA treatment during pregnancy will prevent vertical transmission of hepatitis C and cure the mother. So this slide here shows our trial design. So we're proposing to randomize pregnant women from 24 weeks gestation onwards to either start Sofdal during pregnancy or to not have treatment, so as is the current standard of care. So the drug will be provided free or at cost either from Mylan as pre-qualified generic drug or by Gilead. And just a note of the choice of our drug. So we didn't want to use soft DAC due to safety signals for DAC in multiple species and also because it's not available in high-income countries. And we also chose not to use GP as it's currently not available in low and middle-income countries. So we will randomize women 2-to-1 to the intervention arm so that we get as much safety data as possible from the women who are on DAAs. We plan to start treatment from the end of the second trimester onwards, so after the period of organogenesis is complete and most probably during the period where there is the highest risk for vertical transmission. And then we'll follow the women to birth for the primary outcome, and I'll say in a moment what that is. And then women and infants will be followed on to 6 months postpartum for the secondary outcomes. And just to note, to make clear, we're not following everyone until the control arm have completed treatment, as women may only start treatment at 2 years postpartum, for example, when they stop breastfeeding, and that would make the trial too long and too unfeasible, unfortunately. And then we will do some PK, so both in pregnancy and also during breastfeeding. So women who present later in pregnancy and are enrolled later in pregnancy will still be receiving DAAs postpartum. So there'll be the opportunity to look at PK and breastfeeding among them. And in total, we aim to recruit 510 women, of whom we expect about 460 to present before 35 weeks gestation. So our primary outcome is a composite of different safety indicators at birth, so congenital abnormalities, preterm delivery, pregnancy loss, and low birth weight. And for this primary outcome, it will be a non-inferiority analysis. Our primary analysis population is women who are enrolled before 35 weeks gestation. But as I said, women who present after 35 weeks gestation will still be included. They just won't be included in this primary analysis population, as we expect the outcomes and the effective treatment may be different in this group who start much later. And then our key secondary outcome is vertical transmission. So this is the proportion of infants who have a positive RNA result by 24 weeks postpartum. And our sample size will provide us at least 80% power to address these first two outcomes. And then our other secondary outcomes that we'll be considering, so these include maternal hepatitis C cure, the occurrence of adverse events in both the mother and the baby. We'll look at infant growth and development, at congenital abnormalities identified up to 6 months. We'll look at the duration of breastfeeding, so it may be that women finish breastfeeding early in the control arm in order to access DAAs earlier, so that, this will be an additional benefit to treating during pregnancy. We'll look at quality of life, and then also among women who receive DAAs in pregnancy, we'll look at acceptability and adherence to treatment. So this slide shows our key inclusion criteria. So as I mentioned, we'll recruit women after 24 weeks gestation who are not in labour, and we'll require that they have a detectable HCV RNA result within 60 days of enrolment. And we really want to make the trial as pragmatic and as real world as possible. So women with HIV will be included in the trial as long as they're on an ART regimen that's compatible with Sofdal. And any women with hepatitis B will also be included and be assessed for the hepatitis B viral load and treatment as appropriate. So this slide shows our study sites. So we have 4 sites in Pakistan, which will be led by the Aga Khan University. We're proposing to have 3 sites in Ukraine, and all 3 of these sites are currently operating as normal despite the ongoing war. So we really hope they'll be able to participate. And then we also have 2 sites in India. Just quickly a word on our sub-study. So as I mentioned, we'll look at PK in pregnancy and in breastfeeding for women in the intervention arm, and also look at cost and cost effectiveness, and then also the timing of vertical transmission and of clearance in the infants. So we really hope this trial, if funded, will add to the existing body of evidence, much of which we've heard about today. We hope that by recruiting women across a range of settings with variation by epidemic, so for example, a much more generalized epidemic in India and Pakistan compared to Ukraine, where hepatitis C is more common in key subgroups, such as people with a history of injectable drug use. Also variation by hepatitis C genotype, women both with and without HIV co-infection, and also a range of healthcare facilities, so both public and private. We hope that with a range of settings like this, we'll maximize the generalizability of our findings. By including a control group, we hope we'll be able to disentangle the impact of DAAs in pregnancy from potential consequences of hepatitis C in pregnancy, and the randomized design will reduce selection bias. Our large sample size will increase our ability to detect adverse events. And yeah, we really hope that the potential impact will increase choice for pregnant breastfeeding women with hepatitis C in both high income and low middle income countries. So just a final slide to acknowledge the huge number of people involved in the design of the trial so far to date. So as well as the sites and the academic institutes involved, I want to also acknowledge the PPI partners, so shown on the bottom right of the slide, who have provided input so far and will also be involved in helping us set up and run the study, so helping develop study documents and materials for the trials, help facilitate enrollment, and then of course disseminate findings to the community and healthcare workers and policymakers. And also to acknowledge our other partners who have been supportive of the trial as well.
Thank you so much, Lizzie. This that was a wonderful overview of this really ambitious and I think what would be a real landmark trial if we're able to bring that to fruition. So really excited about that. Thank you for going over that. And I'm sure there will be questions that'll pop up in the Q&A here, and also welcome you to the panel following the presenters. So thank you again for presenting today. I want to move to our last speaker, which I think is a blend between, it's a new look in that it's a surveillance network through the US CDC. Dr. Kate Woodworth is a pediatrician and medical officer on the emerging threats team. She's in the Division of Birth Defects and Infant Disorders at the US CDC. Thank you so much, Dr. Woodworth, for joining us today and presenting on this surveillance network, some of the data that's already coming in and some of the data that we could potentially look forward to in the future. Pass it over to you. Thank you so much.
Great, thank you so much, and really excited to be part of this presentation panel, and it's great to hear about all the amazing research. And I think my talk, like Dr. Gupta mentioned, is really going to focus around a little bit more around surveillance and epi in this population and sort of opportunities for treatment. So I'm going to try to go quickly here, but I did want to give a little bit of background. So I'm going to present about our surveillance for emerging threats to pregnant people and infant network. And so this is really a surveillance approach that was born out of the Zika epidemic, when we realized we needed to better address the issue that a lot of our national surveillance is really event-based at diagnosis. And what we need is information among mother-baby linked longitudinal surveillance. So really to be able to assess outcomes longitudinally in this population. And so while hepatitis C is a nationally notifiable condition, we know that surveillance has been under-resourced even before the strains of the pandemic. And in general, it's really challenging to get information about pregnancy status, let alone pregnancy outcomes, international surveillance. And so that's why we set up this sort of enhanced surveillance to look at these pregnancy-related conditions And this surveillance network looks at multiple exposures, including hepatitis C, but we also fund jurisdictions to look at syphilis, COVID, and also CMV. And so our main partners are state and local health departments. And on this map, you can see those that we fund to do this hepatitis C enhanced surveillance. Within our surveillance networks, our inclusion criteria is pregnant people who have at least one positive HCV RNA test during pregnancy, or up to 1 year prior to pregnancy without any evidence of clearance or treatment. And then we automatically follow any of the infants or children from that pregnancy. Additionally, we also ascertain cases where infants or children are meeting the CST case definition for perinatal hepatitis C, which is here, and then enroll their birth parents. But I would say we have very few cases where that's how we're identifying the dyad. And then we're focusing on births that are occurring 2018 to 2021 for this surveillance efforts. And then I wanted to describe for this group a little bit more about our case ascertainment and data sources. Again, this being surveillance data. So here are 4 data sets that we collect. So we have a maternal data set with information about the pregnant person and their pregnancy, a birth data set with information about the pregnancy outcome, an infant at the time of birth, and then also an infant follow-up data set. And this includes information about the child's health up to 2 years of age. And then we also have a lab data set that includes all hepatitis C labs for moms and babies. And the main way our jurisdictions ascertain cases is through linkages of existing data sources at the health department. And so primarily linking these nationally notifiable positive hepatitis C testing results with birth certificates and fetal death records to sort of determine if that positive hepatitis C result came from a person who was pregnant at the time. And so as you can imagine, this ends up being primarily retrospective identification since the outcome needs to have occurred for these cases to be reported. And so our jurisdictions collect information regarding pregnancy and outcomes from vital records and primarily the birth hospitalization records. And then the infant follow-up data comes primarily from the primary care provider medical records. Jurisdictions use a variety of methods to ascertain who these providers are in terms of doing this infant follow-up piece, from reports on the birth certificate of who the child's going to follow up with to newborn screening data and what providers are receiving that, and also linkages of immunization records to find out where are these infants getting their 12-month vaccines from and going to those primary care providers. But all of this information is coming from existing data sources. So there's no primary data collection. There's not interviews with these pregnant people, for example. Real quick, this is just a snapshot of the variables we collect, the data elements. So for all of SetNet, we have what we call general variables, information you'd want to know about any pregnancy, regardless of the exposure. And then we also have modular variables for our jurisdictions doing this hepatitis C surveillance. So things like, was the provider or was the person treated for hepatitis C during pregnancy? Things like substance use, diagnoses of the infant for neonatal abstinence syndrome, and hepatitis C testing. So I also wanted to share some preliminary data. We are still actively collecting this information, and we're in the very early phases of analysis and dissemination. Many of our jurisdictions have not yet completed that medical record abstraction. So in general, this data is preliminary and subject to change, but I wanted to share a little about our cohort and outcomes. So this is just showing demographics. This is data as of our December data submission, so December 2022. We have 3,725 pregnant people with outcomes that have been reported. And so, not surprisingly, similar to other presentations, even on this call, our cohort is primarily white, non-Hispanic, and we see a very high proportion of people with substance use reported during pregnancy. And then on the right, I also just wanted to highlight, when during pregnancy, these individuals are getting their positive HCV RNA results reported. And so while the majority are being tested during pregnancy, about a third did have that positive result prior to pregnancy. And then I know this group is particularly interested in treatment, and we do have a place to collect treatment. So I asked our analysts to pull some of our very preliminary numbers, which no one will be shocked to see are quite low. So I'll reiterate again that jurisdictions are still completing medical record abstractions, so these numbers will change. So far, we've had about 89 cases that were reported to have received hepatitis C treatment, but we only have dates on 7 of those. And so we suspect that the vast majority of those are sort of historical treatment records that we're receiving. We're aware, I know we have cell suppression numbers for our data set. And so preliminary, I can't share the exact number. We have less than 5 that were reported to be treated during pregnancy, and those were all with DAAs. And so this is something that we'll continue to update as our jurisdictions continue to submit data. We expect numbers will still continue to be too low to make meaningful conclusions about outcomes after treatment during pregnancy, which is why we're really excited about this registry. But we do hope to be able to highlight opportunities for treatment with this sort of set-net approach. And on that vein, we also have started to look at how many people have had multiple pregnancies when they're in our surveillance cohort. So this is not multiple gestation, but rather subsequent pregnancies impacted by hepatitis C, sort of highlighting, you know, that there were missed opportunities for treatment and cure between pregnancies. And so this is an analysis done a little while ago, but overall 3% of people within our cohort have more than one pregnancy in our surveillance system. And again, this is just within that time window of 2018 to 2020-21. So if we had looked sort of broader than that, if we had a larger cohort, we might have had a higher number. But that means 99 people, you know, had a missed opportunity between pregnancies to get treated. We also looked at some of the time between pregnancies. The vast majority had at least 3 months between their pregnancies, and half had, you know, greater than 8 months. So trying to think about time to be treated with DAAs between their pregnancies, and trying to build in some time for breastfeeding as well. I didn't put it on the slide, but only about half of our cohort had initiated breastfeeding at delivery hospitalization. So as a pediatrician, I think that's a huge problem and something that we can, you know, work on in this population, but also noting that for those who are not breastfeeding, you know, again, that's removing one barrier to treatment. So again, something that we'll continue to update as more data rolls in. Real briefly, just wanted to throw out some information on some of the outcomes. Some of the things that we're interested in looking at is sort of highlighting adverse outcomes within this population. So again, vast majority of people reported substance use during pregnancy, primarily tobacco and illicit opioids. And then, you know, within this population, we sort of see higher than you would expect in the general population in terms of adverse birth outcomes, like preterm birth, small for gestational age, NICU admissions, neonatal abstinence syndrome. So again, something that we hope to be able to dive into the data a little bit more to really stratify out some of those substance use versus sort of Hep C. And then I think the last data slide I had was just also highlighting, you know, some of the infant data that we're getting. Again, medical record abstraction is still ongoing, and so we aren't really we don't yet have all of the negative infant testing, but because it's a nationally notifiable condition, we have all of the positive tests that were done on the infants that have been reported. And so these numbers, really the takeaway is that of those infants that we would expect, so all of the infants born to people with hepatitis C in pregnancy, the health departments are only aware of about a third of the infants that we would expect to have perinatal hepatitis C to have been reported. And so just highlighting again, big issues with sort of lack of testing in these infants, but also something that we're really hoping to dive into more and you know, flesh out more of some of the, you know, reasons why, or risk factors, characteristics associated with the sort of absence of testing or even inappropriate testing in the infants, which is something we see a lot of also. So last slide is just, there's a huge number of people involved in this surveillance across CDC, and also primarily I wanted to thank our state and local health departments. And then if there are questions, you know, I'm happy to take them after this panel, but also here's our email for our set-net surveillance in general. So thank you.
Thank you so much, Dr. Woodworth. That was a really useful and I think a very different look at a similar issue that's being discussed here. You know, the surveillance network is going to help establish the baseline of to which many of these single arm studies are going to compare to outcomes. So that's of vital importance. And I think looking forward to infant testing as part of the cascade is another aspect that we haven't completely explored in this community of practice, but obviously hugely important. I'm going to pass over to Dr. John Ward here to moderate our panel, and I invite all our panelists to come on to their videos, as well as our speakers and presenters. So please do come on as well. And I'll pass over to John to introduce our new faces for the panelists. Thank you so much.
Okay, great. Thanks again to all the presenters. That was an incredible amount of information. Really was really rich and a lot to take in and to sort of digest intellectually and bring it together. So I think I really will start there with our panelists. I'd like to start with Nahida, Dr. Nahida Chakatura and Dr. Monica Longo, because I noticed that NIH was a funder of the study from Dr. Eke at Hopkins. So I was interested just to your thoughts about the range of studies presented, any comments you had about those, and how it was relating to the studies that you had funded in the past or were currently are planning to fund in the future. So if you could comment on that, I appreciate it. Thank you.
So, thank you very much. And I want to say thank you for including us in this panel. And it's great to hear all the presentations. I do have to say that we also support Catherine, so that so not just in the future. And so NICHD overall, including multiple branches within NICHD, including the obstetrical pharmacology branch, the maternal pediatric infectious disease branch, and the pregnancy and perinatology branch that Monica and I are in, have supported research related to hepatitis C in the past and ongoing. So we also have led the PregLac activities to help support and increase research in pregnancy and lactating individuals. And we continue to do that through multiple activities within NICHD and NIH with our FDA and CDC partners. So that's where we are. And I'm going to turn to Monica a bit to talk about some of the work that was recently done through the maternal fetal medicine unit. Just briefly to mention the last presentation that was done at the Society for Maternal Fetal Medicine. So I'll turn it to Monica for a minute.
Yeah, so I just want to congratulate all of you for the wonderful presentation you're doing. And I think the study that Dr. Chaknul and Naida alluded is what has started. And I think you guys have taken from there to bring it more and understanding the pharmacodynamic and that is working on about the treatment in pregnancy of hepatitis C. So what they did was a multi, as you know, is a multi-center study. These are 14 center, 26 hospital. And one of the interesting things I think that was just presented, which is not the main primary outcome, which you're probably already aware, is a secondary, was based on maternal transmission, vertical transmission, using those evaluating the viral and the mode of delivery and other characteristics, and to see if there was a possibility of coming up with an algorithm which could allow the physician, now then we might have a universal screening to see women that could be more beneficial, which you could consider now could be your target for the treatment and might make it easier. And actually they found then bleeding and antepartum bleeding, and of course maternal viral HCV titer are the most correlated with the vertical transmission, which is probably known, but at least now we have the data and actually not the mode of delivery. And that older than the viral load might not be that high, and we don't get a lot of preterm delivery, even when the viral load is not that high, that still we have a double of baby that are going to be in the neonatal intensive care unit, as well, double of these baby that are going to be small for gestational age, less than the 5th percentile. So we're hoping with all of you to utilize this data to come up with an algorithm that will allow us for us now then for the screening and the treatment, and might be allowed to understand, working with the FDA, where that population can be, if it can be more targeted at this point, knowing that there is significant consequence in that specific target. But this is my, and I would like to thank you for being, thank you for your wonderful presentation.
Thank you. And that raises some other areas to explore, but I think to get everybody involved in the conversation, I'll turn it over to my colleagues at the FDA, Dr. Tamara Johnson, Dr. Yodit Ballou. Thank you for joining us today. And again, I would love for you to comment on this data. And I think for many on the webinar today, they may not know all of FDA's role in assessing safety and effectiveness of drugs after their license. So, if you would like to sort of let people briefly know how FDA does that and how these studies and perhaps our registry, helps with that FDA role of monitoring safety post-licensure. Thank you.
Hello, good afternoon. And thank you for the opportunity to participate in this webinar. Indeed, I'm sitting within the Center for Drug Evaluation and Research, the Division of Pediatrics and Maternal Health. And my group usually gets involved in consideration of safety with safe use of drugs in pregnancy post-approval. As you understand, when drugs come forward to the FDA, they have information from animal reproductive toxicity studies, which are helpful in understanding, but the animal experience doesn't always translate or predict the human experience, but it gives us a good indicator. We often have a very small number of human pregnancy cases, if we have any at all, from the clinical trial data. So where we find ourselves is trying to get more information for pregnancy, and it does result in looking at post-approval safety studies. The FDA may require these studies, and they would be observational studies such as pregnancy exposure registries that focus on the maternal infant outcomes. You can look at retrospective cohort studies, looking at claims database or case control studies, and then there are also surveillance methods. In consideration of where there are opportunistic studies in pregnant patients, one, consider exploring the collection of PK data. I can see from the studies presented here today in this webinar that there's a lot of work ongoing in looking into the safety in pregnant women, and a really good start with looking at the exposure of the drugs during pregnancy and collecting PK data. And that PK data is helpful because at approval, we have information regarding the adult population. The drug is approved for the entire adult population, and only if there is a contraindication for use during pregnancy or lactation, it would preclude use there. But what we are missing are the safety data, and then the more specific data about drug exposure levels during pregnancy. As already described, pregnancy physiology changes how drugs are absorbed, distributed, metabolized, excreted, and we need to understand that better.
Thank you. Dr. Ballou, any comments?
Good afternoon, everybody. And again, thank you for extending the invitation to the FDA. So I work closely with Tamara, and who sits in the Division of Pediatrics and Maternal Health. My role is I'm in the Division of Antivirals. So my division does the review process for drug approval, which of course is inclusive of a lot of the DAAs that we're talking about today. With respect to adding to what Tamara has said, I don't think I have anything additional to say, but I've also worked closely with Nahida in the past related to antiretrovirals in the HIV, treatment of HIV setting. So I think there's a lot to learn from our experience in how we've come such a long way with antiretrovirals, getting both PK and post-marketing safety information included after approval in a lot of the antiretroviral labeling. So what I would generally say that is, I think you all are doing a great work with respect to getting both PK and safety information, and any collaboration you can have with the manufacturers of those particular products, that would be the way to get the information generated to potentially be included in drug labeling. So we are always available to work with the sponsors of the manufacturing, or the in this case, the DAA. So any collaboration you have, then we can work with the sponsors to get that information included for regulatory purposes.
Thank you so much. That really was that was my next question. So thank you for letting us know that this is the type of data that could lead to that kind of relabeling, by industry. And it's great that that your office is available to help along in that process. So thank you very much for that. Let me turn it over to Devika Bhattacharya, who is a researcher in her own right. So Devika, you may have comments on the research, but you're also here representing AASLD and IDSA. And I thought it'd be a great opportunity to briefly mention what guidance are coming from both of those professional organizations as it relates to pregnant women and infants exposed to hepatitis C virus. And given what you've heard today or some other recent data, are there any considerations that need to be put on the table as those guidance documents are updated?
Thanks so much, John. And so first, also want to really congratulate all the speakers, outstanding presentations. And there's a lot of very interesting data that we on the guidance panel are going to be looking forward to. And also thank you to the organizers for having me. My role in the guidance panel, I'm one of 4 co-chairs of the AASLD, IDSA, HCV treatment guidance panel. And the way the panel works is, there are a group of about 30 plus physicians who are involved in the panel, and we have routinely scheduled meetings where we discuss updates in the data, and also obviously that extends to hepatitis C and pregnancy. And then we make updates at this point twice a year, both on a web-based platform, and then every 2 to 3 years we produce a manuscript that reflects key issues or updates. And so the current guidance for hepatitis C treatment in pregnancy is that it can be considered on a case-by-case basis, but we just do not, as individuals here have so eloquently pointed out, we just do not have the robust data yet to put it in our very familiar green box, where we make those recommendations. And I think, moving forward, the types of data that we, as a guidelines panel, and I have to be very careful because, we can, I want to make sure that I'm saying that the things that I'm discussing here are kind of publicly known and are, and what is presented is going to be presented kind of externally in the guidance. But in general, obviously randomized controlled data are preferred, but we acknowledge that this is one area, particularly in hepatitis C in general, where single arm studies are likely going to be acceptable. And of course, we would like to see large scale studies evaluating both the safety and the efficacy, particularly SVR12 rates in pregnant women, and then also post-treatment outcomes and postpartum outcomes. I think the other thing I would like to put a pitch in for is for the inclusion of women living with HIV, and also the inclusion, although we are kind of a US and North American based guidance panel, we have page views from all over the world, including high page views from both India and Pakistan, and really want to emphasize and really credit researchers in the UK that are planning these studies in international settings, because we really need to understand, kind of what's happening in diverse populations, and those would be welcome. Also really excited to hear about the impact collaboration, and really hope that will be one that will also be conducted ex-US. So I think I'll stop there. And then I have a question for Dr. Woodworth whenever it's time, but thank you.
Okay, thank you very much. Well, let me welcome Dr. Jody Dion from my medical school alma mater, UAB in Birmingham. It's great to have you on, Jody. Just please tell us how what we've presented today relates to your work at UAB, and what you see going forward as important items to consider to better know the safety of these medications for these populations.
Yeah, thanks, John. Thanks, Neil. I want to echo the great presentations, really terrific so far. To me, what I think, we are at this really opportune time, and all the work that you're doing, this coalition to work for global elimination, is coming together nicely. I think that we have learned a lot from the HIV epidemic over decades about how to do good PMTCT trials, how to start them early and not late, because it takes decades to get data approved and all the data that we want. And we've just lived through a pandemic where we see that not including young women of reproductive age and pregnant women and breastfeeding women puts us behind for a long time. And that vacuum is filled with misinformation and disinformation for these diseases that we know pregnant women are particularly vulnerable to. So I think the world is getting it. I think that Preglac, mentioned by Nahida, has done an incredible job of saying these are the barriers, that we all have something to do, whether you're FDA or an investigator, whether you're regulatory, we all have to recognize the protection through research, not from research, for women who are pregnant who want to enroll. Dr. Chappell, I have to tell you, your work has been cited, your study, at least 8 times in the past 4 months at talks that I've gone to and given myself. The trials that are coming out are there's so much salivation for them. At the SMFM conference a few weeks ago, the room was full of MFM. They all wanted to know how to treat and when and with what and when to start. All of these require clinical trials. When I was on the SFMFM hepatitis B treatment guidelines, you can't recommend a treatment if there's no data behind it, even if we think the preliminary data look good, even if we think it's very promising. You just can't put a good recommendation, like Devika was saying, on it without the data. So I think let's use this momentum. Let's use the power that we have wherever we fit on the spokes of this wheel to move this forward. And I just applaud everybody for what you're doing. We're getting there, but it's going to take a lot more work.
Well, thank you, Jody. You were the perfect closing panelist. Thank you very much for that. I think we only have 2 minutes left. I think I want to thank everybody for coming. If you have a very short question, Devika, I'll let you wedge one in here for Kate.
Oh, thanks so much. Just a query as to whether or not cholestasis is going to be captured, since that's been associated in pregnancy and HCV. Thanks.
Yes, we do have a variable to capture that cholestasis during pregnancy. But good to know that's of interest.
Can I ask one quick question, please?
Yes.
Hi, Dr. Chappell. Thanks a lot for, and I echo Dr. Dion's words at SMFM. Quick question. So based on your PK data you showed that there was an increased exposure despite normal time to maximum plasma concentration. Do you, in this tox study, are you guys using the same dose, or do you think that the dose should be reduced based on that PK data?
No, we didn't have any any idea that we would see that. So we use the typical old Epclusa dose, and that's what we saw. But again, there's no evidence that there's any toxicity. But also we're still doing a lot of PK work, PK modeling in pregnancy, as well as looking at the intracellular sibosphere. So so more to come to really kind of figure out what is going on. But again, there's no evidence that there's any toxicity.
Sounds
you.
good. Thank you.
Thank you so much. I think we're right on 1:30 Eastern time. Neil, do you want to make some closing remarks?
No, just to thank everyone, speakers and panelists for their participation today. Obviously, a lot of moving pieces here. The coalition, our objective is to really bring everyone to the table, and we're at the table. So this had been a very valuable experience. This is the closure of our first phase of the community of practice. We'd love to see it continue. Please do reach out. Let us know what your experience has been through the community of practice. Lindsay is posting a poll here just for a few parting questions for you. But with that, and as soon as you finish with the question within the poll, we'll say thank you very much. And I'm looking forward to working with you all as we push this agenda forward and really make sure that the inclusion of pregnant persons within hepatitis C elimination is a reality in the years to come. So thank you all again, and we look forward to continuing collaboration with you all. Thanks so much.
Thank you again. And again, all the materials are available on our website, globalhep.org. And please refer information to the TiP-HepC registry. Thanks again. Look forward to working with you all in the future. Thank you. Bye-bye.
Thank you.
Great job, everyone. Thank you.
Thanks, everyone. Thank you.
Thank you. Really, really great job.
Thanks all.
Thank you.
Thank you.
Good to see you, Debica.
Same, Nikita.
Bye-bye.
Thank you. Bye.